Hello, my name is Jordan Cotton. I'll be presenting on a beginner's guide of MDT to treat low back pain. These are our objectives. If you'd like to pause and look, you're more than welcome to do so. A little information about myself. I have a bachelor's in exercise science at Marsh University. I graduated PTA school from Shawnee State University. I've been practicing as a PTA since 2018. 4 years of that was working directly with the MDT certified specialist. The majority of my caseload is spine. 80% was cervical, 20% was lumbar. I've taken Mckenzie Part A as well as Part B twice. And so A was for lumbar and B was for cervical. How common is low back pain? So in 2020, approximately 7.9% of the global population were affected by low back pain. Low back pain is also responsible for more disability than any other condition. So what is exactly MDT? So MDT stands for Mechanical Diagnosis and Therapy. It was developed by Robin Mckenzie. He was a physical therapist in the late 1950s. Excuse me. It's a system used to assess and treat musculoskeletal disorders, particularly those affecting the spine and extremities. It emphasizes symptomatic and mechanical responses to repeated movements. It's considered to be very safe. It uses a force progression system to ensure safety. So with MDT testing, you have a lumbar spine assessment sheet. You have your general subjective history, past medical history. Then you ask these red flags, which essentially helps with one of the classifications in the MDT classification system. You measure baselines like range of motion, manual muscle tests, pain, and you want your functional baselines too, like what do they have issues with. And if they're considered to be safe for repeated movements, then you perform the movements. And based upon what they respond to, those repeated movements helps with determining the classifications. So we're going to talk about the classifications here, and one of the most common ones is the derangement, and it's considered essentially a mechanical obstruction of joints. This is usually associated with like loss of range of motion and a rapid change in symptoms typically. That's when you have like the centralization and peripheralization. For dysfunction, it's basically adaptively shortened soft tissues. Think loss of range of motion, pain at end range, but no residual pain after you've stretched that at the end range. One example was kind of like a total knee replacement when you're stretching them. Postural, it's basically pain caused with prolonged static loading of the tissues. Typically, they sit for 10 to 15 minutes and they start having low back pain, and that would be considered postural. And usually it's resolves with just correcting it. And then you have the other, which I mentioned earlier. Those kind of help with more of those red flags, if those red flags are present. Or if you're doing the repeated movements and nothing really makes sense, this would also be considered in this category too. So we're going to try just some classifications here. So this first one, the patient has shooting radicular symptoms from the lumbar spine to the left foot, feels better with walking, worse with sitting, very stiff in lumbar extension, but the prone press up seemed to centralize the symptoms to the left hip. What would this classification be? And so you can pause the video if you'd like, but that classification would be derangement. It's one of the most common ones in what we see with using MDT. The next one, we have a patient with low back pain, an end range flexion. Repeated lumbar flexion produces the pain every time, but alleviates when he stops doing that. No symptoms of the legs, no numbness or tingling. What's the likely classification? And that classification is dysfunction. This other one, patient 16-year-old teenager that has low back pain after sitting about 15 minutes unsupported. When he corrects his posture, the pain pretty much goes away. What's this likely classification? And then that would be the postural classification. And this last one we're going to go over. Patient has had constant back pain that started about a month ago, unsure what caused the pain. Later mentions that he's had lost a lot of weight unintentionally and sweats a lot at night, almost every night. What is the likely classification? And that classification would be considered other. He's displaying some red flags, so you'd want to refer them out, and essentially that's how the classification system works. Now, with using the MDT, they use a traffic stoplight to kind of help determine with what they're supposed to do as they do repeated movements. So if you look in the terms here, they have a bunch of terms here. A lot of them are self-explanatory, but the ones that are a little bit more confusing are like the better, no better, worse, no worse, because they sound, similar. But essentially, abolish, centralize, decrease. Anytime those symptoms do that, that's considered a good thing. So that's the terms used during the movement if those things are occurring. Now, where it becomes better, no better, worse. So because centralizing, abolishing, decreasing symptoms are considered good, if they stay good after you do the repeated movements, that would be considered better. Now, if they have those things happen, but afterwards they go back to their baselines and it doesn't stay better, that's would be considered no better. Same thing with worse. So you have like your produce, peripheralize, increase in symptoms. If they continue to stay that way after the testing, that's considered worse. If they go back to their baseline, like if they have the pain or the increased pain, the peripheralization during, and then it goes back to baseline, then that's considered no worse. And then you have a no effect. So based upon those terms, helps you determine what you should do with the light. So if it's considered red light, you would stop movement, change direction. Yellow would be proceed with caution, increase the force, and then green would be continue or increase the force. And essentially what you have is anything that becomes worse, you would consider it'd be a red light. You would stop movement and change direction. For the sake of this presentation, we're only going to talk about sagittal movements. And if you have anything that's considered no worse, no better, then that would be like a yellow light where you proceed with caution, but you would increase the force to see how they respond, whether they're truly a green light or a red light. So, and this is just basically summarized, also to include like if range of motion changes too. You always want to use your baselines. If the baselines improve, then that's considered a green light. So with these progressions, this is a exhausting extension. This isn't all the extension things you can do, but this is generally what they typically do. You try prone lying, and you just increase the force. So what that looks like, you want to do repetitions on repetitions to see whether they're a yellow, green, or red. If it's really not conclusive, that's kind of considered a yellow, and then you would progress the force to see if they change. And then based upon that, using yellow, green, or red, you can determine what they need to do next. And they usually use that for a treatment too. So this is the same progression, but with flexion. So you have supine, standing, and seated. So I'm going to go over just like what the effectiveness of MDT is for low back pain. So in this article that I found that there was moderate to high quality evidence that MDT was superior to other rehab interventions for reducing pain and disability for chronic low back pain, but there wasn't as much support for acute. MDT was considered superior when compared to generalized exercise, education, and placebo. Interesting though, when it's compared to manual therapy, which had like manipulations and mobilizations combined with exercise, it actually had similar results. So that's actually that's pretty good because a combination of two was similar to MDT. So this next article I thought was super interesting. So there was a study that they did where it was a study of prevalence of extremity pain of spinal source. So they had 369 participants. The inclusion criteria was basically participants that had isolated extremity pain, which could have been upper or lower, who believed their pain was not originating from their spine. So the interesting thing about the study was that they found that 43.5% participants had a spinal source of symptoms. So which means the symptoms were improved with spinal intervention. So what's more interesting, we're talking more about the lumbar spine. Participants with hip pain found a 71% spinal source. Thigh and leg was 72%. This was interesting too, 25% for knee, and then 29% for ankle foot. So it's like 1 in every 4 patient that you would have with those symptoms had a chance of coming from the spine and actually respond better to spinal interventions. So the key takeaways from this, we know that based upon the research, MDT can be very effective for treating low back pain, especially with chronic low back pain. MDT is a safe method for diagnosis and treatment, due to its force progression system. Isolated lower extremity pain have a high likelihood of spinal source, and because of that, you always want to screen your lumbar spine with insidious symptoms, especially for hip and thigh. So this next page is my references.